Hello, everyone. My name is Tina Lining. I am the Director of Diversity, Equity, and Inclusive Excellence. And on behalf of Dean Gerson and the School of Medicine, we welcome you to Vitals, virtually inclusive talks and lecture series. Today, our guest speaker is Dr. David Margolius, who will talk on the subject, Racism as a Public Health Crisis, Envisioning the Future. Dr. Margolius is the Director of Public Health for the City of Cleveland. He is the first physician public health director in over 40 years. Dave was born in Cleveland and raised in Shaker Heights. For the past 7 years, he worked at the Metro Health System as a primary care physician and also the Director of Internal Medicine. As an active educator, he is associate professor here in the School of Medicine, and he is also faculty for the Medical Directors Leadership Institute at Harvard Medical School Center for Primary Care. He has been published in numerous peer-reviewed journals on a wide range of public health topics, from COVID-19 responsiveness in underserved communities and the opioid crisis to hypertension in low-income populations and best practices in primary care, preventative medicine, and family medicine. Dr. Margolius holds an MD from Alpert Medical School at Brown University, and a BA in biology from Brown. He completed his residency in internal medicine at University of California, San Francisco, where he spent his last year as chief resident of quality improvement and patient safety before returning to Cleveland and joining the Metro Health System. He lives with his wife and 2 children in the Old Brooklyn neighborhood of Cleveland. Dr. Margolius's vision for the Cleveland's Department of Health is for it to become the most responsive, the most trusted, and the most impactful health department in the country. With that, Dr. Margolius, take it from here.
Got it. Our division of health includes many different facets, all the way from preparing for bioterrorism and the next pandemic to printing out birth certificates and death certificates for the whole county, really anybody who asks. And then our newest division, Health Equity and Social Justice, was started when the city of Cleveland, the city council, declared racism as a public health crisis. Instead of it just being words, this came with a whole division, which has 3 programs, as you can see there, and we'll have up to 15 people any day now. We've got some offers out, so it'll be a full division. A little bit about me. So as Tina mentioned, I grew up in Shaker Heights. I was born in Cleveland. I'm 6th generation Cleveland. I went to Brown University for undergrad and med school. While I was out there, I learned that there was this primary care shortage, this crisis. I read a lot of what some guy named Kurt Stange was writing, and a lot of what was being published in his journal, Annals of Family Medicine, written by a couple folks out in San Francisco. I reached out to them and said, I'd like to take a year off and spend some time understanding this primary care crisis. Could you host me for the year? And they said, yes. That sounds great. We love people from Cleveland. And so next thing I knew, I was out there in San Francisco. I did a year working in quality improvement work and practice improvement work in primary care space, working with the health department. I stayed on for residency. This is me in my final week as residency. As you can see, I'd become an expert at this point. And there's this tradition where the third-year residents who are able to grow a mustache to scare the incoming interns into thinking that by year 3, many of them will have mustaches. So that's me. I stayed on for a chief resident year where I perfected my skills of speculum exam in my ear. This individual who's doing this exam is now the head of maternal fetal medicine for Ventura County in California, major public hospital out there. And then it came time to leave San Francisco and find a place to live. And as many have heard this story on the call, I was ready to find someplace out west. But my wife, who is not from Cleveland, said Cleveland is the best place on earth. That is where we need to move. And when we, if we go there, if we leave San Francisco and Cleveland, I think you can make a difference. I think we can make a difference. So we moved to Cleveland. I started working at Metro Health because I just Googled which one was the safety net healthcare system, and it was Metro. During COVID, I had the great honor of leading a lot of our COVID response work, including the COVID hotline, helping to set up our community testing, and then that rolled into our community vaccination program. But through the course of leading the COVID hotline, I was frequently in contact with our media relations team and did a lot of publicity for the work that we were doing, helped engage with the community on all these different pieces. This was a great video that they put together that really honored the work that we did. And I think all that lined up in positioning me to, when the job for Director of Public Health was posted, a number of friends and colleagues sent me notes and said, you should really apply for this job. And I said, no way, I could never leave, what I got going here at Metro Health. But as I reflected on the opportunity, it felt like something that I just couldn't pass up. And so applied for the job. And here I am being sworn in, and instead of a Bible, somehow my hand ended up on my youngest son's head. So, Director of Public Health, City of Cleveland, how is the public health of Cleveland? And that's what we're here to talk about today. So, as many of you on the call know, the life expectancy for Clevelanders, the quality of life for Clevelanders is vastly worse than that of our suburban neighbors. And so this is illustrated really nicely here, where the Buckeye Woodhill neighborhood is just called out here, has a life expectancy of about 65, just a mile away. In Shaker Heights, where I grew up, life expectancy is 88. The reason for this disparity in life expectancy is structural racism, is racism more generally. And so as we will talk about, this gap in years expected to live between people who are white and people who are Black, the reason for this gap is because of racism, because of a public health crisis. And so my objectives for this session are to talk about race as a social construct, not a genetic proxy. There's nothing wrong with the genes of Black people to cause them to live less long in Cleveland. It is racism. Racism impacts public health via systems that oppress and individuals that discriminate. We would like to, not to be all doom and gloom, and we'll talk about what the City of Cleveland and the Department of Public Health are doing about it, and what we all can do about it. There will be plenty of opportunities to think about how CASE can help with this, how medical education, how all the clinicians, the clinical folks on the call can help work on this as well. So small order, just figuring all that out. Racism as a public health crisis in Cleveland is not complete without a redlining map. So this is a map from the 1940s, 1940, where neighborhoods marked in red were described as having too many colored people, as their words, I think was the exact words, and therefore not worth investing in. And folks who are white or who had wealth were discouraged from pouring investments into those neighborhoods. As a result of that policy and other policies like it, people who are Black were segregated and are segregated to this crescent, this Cleveland crescent, this C in Cleveland. So what we've done through structural racism over time, though unfortunately the royal we, is taken folks who have the most things stacked against them, the least cumulative wealth. So this is a graph showing lifetime wealth, racial wealth gap over time, where for every dollar of wealth a average white family has, a Black family has 12 cents. That is due, number one reason is because of a gap in intergenerational transfer of wealth, whereas someone who is white is much more likely to have a large inheritance compared to someone who is Black. And segregated, created neighborhoods that have increasing high rates of people who are Black and highest rates of people who are in poverty. And as a result, a much lower life expectancy in those neighborhoods, not because of the color of their skin or their genetics, but because of these factors that have made these neighborhoods less nourishing, less supportive of a long, healthy quality of life. So that's what this looks like. I'm just going to throw 3 examples on the page. Traffic fatalities in Cleveland are one of the leading causes of death. Traffic fatalities disproportionately affect neighborhoods on the east side of Cleveland, as you can see here. So this is from the Vision Zero Cleveland map. And if you make the walk or the bike ride or even the drive from the west side of Cleveland, or even the inner suburbs on the east side of Cleveland to the east side of Cleveland, you can see the difference in investment and how that impacts health. And one of the most direct ways it impacts health is because people are getting hit by cars and dying due to the lack of investment, and that changes life expectancy and quality of life. Unfortunately, just yesterday or this morning, there was someone, a 15-year-old child who was in critical condition from a traffic fatality on one of these red hotspots for crashes. Another example, lead poisoning. So the more yellow, greenish yellow the map, the more higher the rate of lead poisoning. And as you can see, it's the same map. Due to systematic underinvestment of the homes in these neighborhoods where Black people have been segregated to, there are much higher rates of lead poisoning. And this is a problem that in Cleveland has gotten a lot of attention. And solutions are coming. The money is there, the money is collected, thanks to many of you on the call who are involved and advocating for that. And now we got to spend the money and invest in these homes, which we'll talk about. And the third example is Wi-Fi, broadband connectivity. So, in healthcare, we have gone all in on patient portals and saying, might not be someone answering the phone, but like you can always use MyChart to get in touch with someone. Well, that, as we know, is inequitable because of infrastructure and broadband. So even if you had all the money in the world and you live in central Kinsman neighborhood, these red areas, you can't get as fast internet as if you live in one of these well-invested neighborhoods, because the infrastructure, the dark fiber, the broadband that I'm learning about isn't there. One more example, trees. So trees make people healthy. A lot of data showing that the more trees you have, the less pediatric asthma, less traffic fatalities, the less even gun violence. There's some new data coming out about how that built environment from trees. So the tree canopy in Cleveland, as many folks on the call will know, has shrunk over time, even though we are the forest city and we're trying to fix that. But inequitably, the tree canopy losses happen on the east side of Cleveland, those same neighborhoods. So I hope the how is becoming clearer and clearer. And I know you wouldn't have signed up for this talk if you didn't already have some kind of inkling of how this all has played out in Cleveland's health. Racism is an organized social system in which the dominant racial group, based on an ideology of inferiority, categorizes and ranks people into social groups called races, and uses its power to devalue, disempower, and differently allocate valued societal resources and opportunities to groups defined as inferior. So that is David Williams, sociologist at Harvard, and he describes those facets of racism that affect health in three buckets. Structural racism, which is the example of redlining, Jim Crow laws, the other policies and procedures that excluded people who were Black or other minorities to oppress racial groups. Cultural racism, which is the imagery, symbols, and media that spread or normalize the stereotypes that allow people to not lose sleep over these huge disparities. And discrimination, which is conscious or unconscious act of treating racial groups differently, which we'll talk about a little bit deeper in the next couple slides. So there are two kind of discrimination Dr. Williams breaks this into that I want to walk through. There are major experiences. So have you ever been unfairly denied a bank loan? Have you ever been unfairly discouraged by a teacher or advisor from continuing your education? And follow-up questions, was that unfair discrimination due to your race? So in many cases, folks can read this and say yes to a few of these answers, regardless of your race. But for minorities, and particularly Black people, they're going to answer yes to more of these questions than other folks. And then there's everyday discrimination, which is, not necessarily getting denied a bank loan, but it's just you're getting treated with less courtesy than other people. You're being presumed to be not the physician when you are a physician, whereas your white male colleagues don't get that same treatment. You're threatened or harassed. People, when you walk into a store, people think you're there to rob them. Chronic daily occurrences. And so if you looked at this and this is your daily experience, then you already know. If you look at this and this is not your daily experience, then I would recommend you watch this 26-minute film called Toxic that a number of folks on the call and others in our department put together as part of First Year Cleveland to show how those daily chronic stressors contribute to the loss of life and the loss of quality of life. And you can watch it either way. It's 26 minutes, it's on the website, but it's just a 26-minute snapshot of what those chronic daily stressors look like. So in summary, how does racism impact health? Structural racism leads to this wealth gap, creates segregation. Segregation of everybody who's poor into certain neighborhoods creates pathogenic residential conditions that cause premature death, disease, disability. Discrimination causes chronic daily stressors, reduced access to goods and services. And all of those things contribute to the worst quality of life, higher stress, higher rates of hypertension, higher rates of heart attacks, and so on, that contribute to this. So much of this is really obvious, right? Hopefully when I spell this out, right, that racism takes lives, that racism is a public health crisis in that it causes people to die before they've reached their full potential. And it shouldn't be, at this point, we shouldn't have to explain that people's life expectancies differ because of their genetic makeup. However, we still have a lot of examples in healthcare and in society where there's an implication that the health of Black people is different than the health of white people because of their genes. And so I'm going to talk through that. So race is a social construct. It is not a genetic category. So please stop. Folks will often ask, well, what about sickle cell? Like, isn't it helpful to know someone's Black? Because maybe I'll know if they have sickle cell and that'll change the treatment. While sickle cell does impact some Black people based on their ancestry, it also impacts a number of other populations in the Arabian Peninsula and Southeast Asia based on their ancestry, not the color of their skin and their race. And there are other examples of how ancestry impacts certain genetic risk factors as well. We know about Tay-Sachs disease and Ashkenazi Jews and things like that. It's an ancestry association, not a race association. Race is a social construct, and yet healthcare treats it as a genetic category. So heart failure. I see some cardiologists on the call. I don't know if I have any. I saw a pediatric cardiologist, our kid's pediatric cardiologist, although I don't know if there are any adult cardiologists on the call, but in cardiology, in the guidelines, when you get to like step 3 of heart failure treatment, if your patient is Black, you prescribe these medicines. If your patient is white, you start to talk about, well, what about cardiac transplant? What about an LVAD, the thing that Dick Cheney had? Or what about a more palliative approach to taking care of them? These medicines are taken every 8 hours. They have terrible side effects. And it says in the guidelines, if the patient is Black, prescribe them these medicines. And it might seem like a minor thing. Oh, they did a little study, and that proved a benefit for Black people, and that's what they were looking at. But given that we know race is a social construct and not a genetic category, it's very problematic that this remains in a guideline. And folks have written about this, including a former mentor of mine, Kirsten Bivens-Domingo, who's now the lead editor at JAMA. Another example. Fortunately, we just about fixed this one. When you're calculating out someone's kidney function, if their creatinine is high, this blood test that we do, we say, they've got potentially have kidney injury, acute kidney disease, chronic kidney disease. If their age is high, we worry a little bit more about their kidney disease. If they're female, we worry a little bit more on their kidney disease. But if they're Black, prior to this change in this calculator like 6 months ago, you'd say, oh no, they're good. We use that race category to say, they're allowed to have a little bit higher creatinine because, well, something about Black people and muscles and therefore their creatinine is higher because they have more muscles. Literally how this was explained. Fortunately, as of February 2022, the guidelines changed. And for most of our healthcare systems now, the race coefficient has been taken out of the calculators. 2022, years after it was known that this was problematic. And so hopefully folks have experienced that this has come out of their calculator. Hopefully folks have had conversations about why this is important, because ultimately this is one of the reasons why this is important. In studies that look at the same medical condition, in this case, a broken bone, Black patients compared to white patients are much less likely to receive treatment for their pain. And so deep down inside, there's all the discrimination factors that we talked about, but the system is telling them that Black people have more muscles, their creatinine is higher, and they can handle the pain better. And so this is extremely important. When we talk about racism as a public health crisis, it includes all of this, right? The point is to take it away from genetics and recognize that there are systems in place, systems that oppress and individuals that discriminate that create this life expectancy gap, not some difference in genetics. We've talked about the systems, but here they are again. So what do we do about it, right? we recognize it, we've called it out. A number of cities have declared this is a problem. The health department got a whole division out of this to work on these issues. But part of the title of this talk is not just describing public health, racism as a public health crisis, but also envisioning the future. Ending the wealth gap is one of the most important things that we can do to change the conditions. So in many cases, what that looks like, if you want to tackle it head on, is reparations. It's not the taboo topic that it, once was. The state of California is looking at it and considering it. A study came out in JAMA just a few months ago showing that they were able to model out the impact of reparations on health, and they found that they just about closed the life expectancy quality of life gap through reparations. The reparations, the dollar amount is very high, but it's the most direct way to address this issue. Now, it doesn't completely address this issue because of all the other factors that we talked about that create this life expectancy gap, but it's a big part of it. The other component is segregation. So we've got pathogenic residential conditions in our neighborhoods that are predominantly Black in Cleveland. We could address that by integration. So taking people who are Black and encouraging them to move into communities that have been better invested in. And some of that, as we know, is happening. Or vice versa, having white people move into predominantly Black neighborhoods to increase the investment, called, often called gentrification. Or we could work on investing in these neighborhoods to reverse the pathogenic conditions that have created these life expectancy gaps. So it's a lot to think about, and we'll kind of talk through some of the work that we're doing through the city of Cleveland and our partners. I'm going to list 3 examples of how we're trying to change the pathogenic residential conditions in these segregated neighborhoods. The Complete and Green Street Initiative and transit-oriented development has the intention of looking at these hotspot intersections where the majority of traffic fatalities and pedestrian on-vehicle fatalities happen, and making the intersections better. Slowing down traffic through speed tables, better walk signals, better visibility, more protected bike lanes, more protected walking paths, all in the spirit and making sure focusing the investment on the neighborhoods that need it most. So that work is happening. It's really slow, and it costs billions of dollars. And there is funding for this from the federal and the state level, but it's slow. And you see it, and when you see construction on a road, it tends to drive everybody a little upset, right? Because they're like, oh, this huge inconvenience and it takes forever. But the work is being done, and we'll continue to do that work. For a lead poisoning situation or crisis, the Lead Safe Coalition groups involved in this call have raised $117 million to work on this and make homes lead safe. Through our federal grant called ARPA, the American Rescue Plan Act, we are spending almost $200 million on a program called Housing for All, which has a lot of different parts, but is essentially making sure that we have enough housing in the city of Cleveland, and that housing is safe and affordable. And so that means helping people stay in their homes if they want to stay in their homes, but they need to rehabilitate their homes so they're safe. It's building new homes, it's building new apartments, it's building new condos, and it is demolishing homes that need to be condemned, which also is expensive and takes work and takes a lot of legal work to get through the process, to make sure that there are no 6th generation next of kin. But it's important work, and that's the work we're doing there. And then, it might seem like a minor thing. I don't think it would seem like a minor thing to anybody on this call, but solving this broadband connectivity gap is something that we can accomplish really quickly, hopefully, fingers crossed. The investment is there, the will is there, so we can create the infrastructure so that anywhere in the city of Cleveland, you have access to fast broadband, and that does have implications on health. What else are we doing? So the lakefront, it seems small. It seems like we've been talking about it for forever, the Burke Lakefront, the whole thing, but it matters, because when you go to the west side of Cleveland, this is your beach. When you go to the east side of Cleveland, this is your beach. It's an airport that nobody uses, or very few people use. So that matters. That access to green space matters. The riverfront matters too, as we're learning. As far as 6 issues that I'm trying to focus my attention on with Cleveland's Department of Public Health, we've talked about some of them. Smoking, for me, is number 1. Cleveland has the highest smoking rate in the country, based on a recent thorough measurement from 2015 from Dr. Trappel and team. Smoking is the leading preventable cause of death, disability, disease. So if we can bring our smoking rate of 35%, 1 in 3 adults, down to the national average of 12.5%, which I think we can do, I know we can do, that'll have major implications on quality of life and life expectancy for Cleveland's residents. Now, interestingly, this is not, smoking isn't really divided on racial lines. It's bad everywhere in Cleveland. It's more divided strictly on poverty. And so the smoking rate for white Clevelanders is 35%. The smoking rate for Black Clevelanders is 35%. Smoking rate for Latino Clevelanders is 35%. So that's something that we hope to change. And anybody who wants to participate in helping us change that, you are welcome. Please reach out to me. More to come on that. Gun violence, we read about it every day. Homicides, we're up to 155 this year. 155 people have died from homicide in Cleveland in 2022. That is a public health crisis. Lead poisoning, we've talked about. Cars, we've talked about. Overdose deaths from opioids. The group with the highest rate of increase in deaths from opioid overdose are Black Clevelanders. And so we need to do more there. Narcan is part of that solution, but access to treatment is a part that we haven't done enough. Everybody who's able to should be able to prescribe Suboxone, and anybody who's ready to get treatment from Suboxone or methadone should be able to sign up and get Suboxone or methadone, but that's not the case currently for a number of different reasons. And then poverty is obviously underlies a lot of these issues, but I do think that in public health, we can address it head on instead of just circumventing it and talking about other ways that we can help. So I think we can address poverty head on as a public health intervention. Here are some things that we're working on so far. It's been a few months, and so I recognize that I won't be able to say I'm new forever, but right now I'm new, so it's all work in progress as we're developing this work and actively looking for partners to participate, especially if those partners are live, work, and play in the community of Cleveland. Those are the groups that we want to interact most with. Food justice, Darcy Freeman and team and the Nourishing Power Network are a big part of how we're reframing solving that issue as well, and being a part of that solution. So we thank you for that. So in conclusion, racism is a public health crisis. This gap in life expectancy is from racism. And so I look forward to partnering with all of you on this call, and I love just the response rate alone on folks signing up for this work. I've been overwhelmed by the response since coming to the health department about how wonderful the people are in this building, and also how excited people are to partner with your local health department. And so I look forward to continuing that into the future. This is a picture of some folks on my team and my boss, all my bosses, and from our lead safe walk from a month or two ago. I don't know, all the time. It's all blending together. It was a little warmer. So whenever that was. But with that, that's my last slide. And so I think if we can, I'll open it up to questions. And I see some chats here in the thing. So I can start to address those if that works, and we'll go from there.
Sure. Thank you so much, Dr. Margolius. We really appreciate your insight and expertise in this area. So we have a couple of questions here. And I think when you were talking about the areas that you're focused on, someone asked about infant mortality.
Yeah, thank you. So we have the largest infant mortality reduction program based in our health department. We're also a funder for First Year Cleveland. So definitely one of our priorities. And I think in addition to the work that we're doing through our Moms First program, which staffs out community health workers for expectant mothers through the first 18 months of life, addressing smoking and poverty and all the other factors that we talked about is how we address infant mortality. That's our plan. I mean, we're working on connecting the care and those bridges, but we really want to address those upstream issues head on to be able to make an impact for infant mortality. So many different causes of death weren't listed on the priorities, but getting at those root causes is the plan. And I'll keep going through the questions. Is that okay?
Sure, go right ahead.
Okay, or if I see Dr. Evans has a question, we can pause for that. Yeah. You gotta unmute though.
And you can unmute yourself and ask a question if you want, and we'll also answer the questions in the chat.
I apologize. Thank you, Dr. Margolius, for a wonderful talk. There's so many questions I could ask, but one is about reparations. And you mentioned that it's not the hot button issue that it used to be. I'm not certain in my experience that I would say that's so, but I'd like you to say—
it was not the faux pas taboo subject that it used to be. I think it's becoming more mainstream.
I hope so. But I would like you to say more about what it means, because in my thinking, it isn't just about money. It is about money because all of the things that need to be repaired will take money. But it's not just giving money to people, it's giving money to institutions and programs that will help persons who have been deprived generationally know how to have a good life. And that is very complex, I think. You know, it's school systems, job opportunities, a lot of things. So I don't know if you have more you want to say about it. The other thing is about racism and what it means. And I think to make progress, we have to work on with all of our colleagues understanding what racism really is about and accepting that we have it and that it is something needs to be done about. And I think there's still people who say, well, I'm not a racist, as if that means you're the devil incarnate. And so that denial can prevent progress. So those are the two comments I would make.
Okay, agreed. I respond. So yeah, reparations. I think we underestimate the power of giving money to people, and often we'll give them to institutions who think that they represent the people. And so I do have concerns about that approach too. But I agree, it's all of it. But I don't want to underestimate the power of giving people money. And the most capitalist society in the world. And so I just want to acknowledge the power there and what we've taken from people.
Right. Actually, I had one more thing, and then I will stop. I think everyone is aware that even if you're looking at an upper middle class or upper class person of color, the infant mortality rate and mother and maternal mortality rates are still higher. And I think that is the reason. I think I understand what the reason may be, but I don't think it's generally understood. And that is that there's a lifelong stress just from being a person of color in our society, which has a great impact on whatever health outcome measure you're looking at. So again, it's about structural things that have to be addressed over a long period of time. But just to be a person of color, whether it's recognized consciously or not, is a stressful existence.
Thank you. Agreed.
Yes. Thank you. Thank you.
So I
much.
see Brooke asked about fentanyl test strips, and because he, knows, maybe he saw it in the background, but here are my fentanyl test strips. So I hope they're not illegal. I don't think they're illegal, but someone correct me if I'm wrong, or you can have me arrested if you didn't like the talk. I'm here.
Don't worry, we'll bail you out.
You're right.
Yes.
Thank you.
So another question was from LaShawn, and she says, what is the plan to eliminate or provide areas that are in a food desert?
Yeah, so one of my maps that you can see in the background right there is my food apartheid map. As I've learned to reframe it. And so the mayor signed on to a pledge with 200 other mayors to end childhood hunger. In a lot of ways, the children in our city are not hungry. They are being fed. What they are being fed is not so good, as many of you know. What we're trying to do there, and again, this is supporting Darcy Friedman and others who are doing this work, and so I'm being educated by my peers, my colleagues, and the folks who have done this work. But we are trying to create food justice or food sovereignty, which means that people in our communities that have been historically disadvantaged have the power, the ability, the access to grow, eat, sell healthy food. And so how we're going to do that, there are lots of different ways and lots of different groups working on that. But I think as a health department, we want to be here to support that, whether it's through a literal letter of support on our letterhead or going for funding together, or whatever we need to do to make that happen.
Yeah. Thank you, David. And this will lead into Dean Gerson's question, which says, he says, it takes a city, not just a village. And he said, so how can we help you promote attention to averting racism towards community health throughout the city?
Well, thank you, Dean Gerson. And I know some folks have ended up on this call because you gave a shout out to this talk at your some address that you gave recently. So I appreciate you for that. I think that one of the ways, there are so many different ways that you can help and already have helped. I think looking through the curriculum and finding those examples where race is described as a genetic proxy would go a long way. I think there are more opportunities. A lot's been done, but there's more.
Okay, thank you for that. So another question says, can you share how mental health care is incorporated into Cleveland's public health goals?
Yes, so we are getting directly involved in mental health crisis care. As some folks on the call will know, there was a proposal to expand our co-response model, which means for a mental health crisis where police are called, police would go out to the scene with a clinical mental health professional. They've been doing this, they've been piloting it. They have 5 individuals right now from Frontline, on loan from Frontline, that do this work. It's been very successful. They went to go expand it. And thanks to activists in the community and some flexibility through the city government and the mayor, we are adding a care response model as well. And a care response model means that it's basically a non-police crisis unit that would respond to mental health crises. Now, as folks will know who study this work and do this work, crisis care for mental health is only one part of a continuum. And so it can't start there and end there. But it is an important part, and it's a part where we at the city think we can fill that gap. So that work will be led by the public health department rather than public safety, and that was thanks to an amendment and work done at the city council table. So local city council really does matter for these types of things. So that's how we're hoping to get involved. That was that little purple box on that org chart on my first slide.
Great, thank you for that. Really important work, thank you. So another question, are there specific health behavior theories or models that you are using to render interventions for these healthcare disparities?
All right, say that one question, where is it one more time?
Okay, it is It says, are there any specific health behavior theories or models that you are using to render interventions for healthcare disparities?
Oh, that's an excellent question. I don't have a great answer to that. I think I've been influenced by many of you and many different folks from within our department, with the city, within the group. I don't have a good answer on an overarching framework. Open to ideas.
Great, thank you for your transparency. Are there other questions that, if you have a question, feel free to unmute yourself and jump right in.
Hi. Oh, sorry, LaShawn. Sorry. I did put this in the chat, but I know there's a lot of questions in here. I was wondering if the city currently has plans to allow for greater access to higher education, or education programs past high school, also helping with the Cleveland City schools and retention of students through graduation. I'm sure there's always been kind of focused work in that area, but if there's any new initiatives.
Great. Yeah, no, it's definitely one of the top priorities for the city, as you've all seen with the news of Eric Gordon stepping down at the end of the year. Education is a big part of our weekly cabinet meetings, and the goal being that, why not us kind of thing? Why shouldn't we have best education and folks who want to stay here for high school? It's personal to me. I have a first grader and a pre-K student. The first grader is in CMSD schools. The pre-K student is at Music Settlement, but will be joining CMSD next year. And I am the one cabinet member with CMSD student of all the cabinet members, not because people have chosen to live other places, but because of their kids are different ages. So the mayor will say, point at me and say, what's it going to take, to get you to stay in CMSD schools through high school for your kids. And so it's a priority. And we'll see more in January. There'll be a $30 million investment plan, and some of the work that we're doing around that from an ARPA proposal.
Thank you.
Thanks.
Next question.
Hi, Dr. Margolius. I want to build on what my colleague Deidre said about education, but also having access to exercise, because I know growing up for me, the YMCAs were very vital in the community, but unfortunately, the only one I could think of is near Cleveland State. So I know there are so many other initiatives, but I'm just wondering if that's on the table about, just rebuilding at least one strategically somewhere so that, folks will have an opportunity.
Thank you.
To
Thanks,
exercise.
LaShawn. Yeah, there is one also in West Park. So to the point of everything we've been talking about, right? So the city has over a dozen rec centers of variable quality, and many of them don't get a lot of use. And some of them are in pretty bad shape, and some of them are in pretty good shape and don't get a lot of use. So we've got to figure out our plan for all of the rec centers, and maybe it'll include working with the YMCA to figure that out. But I know that group who's over that department has started to lay out their 20-year plan and trying to get community engagement. Where we're like, all right, maybe we don't need this many rec centers. Maybe that made sense at one point, but let's invest. Let's do quality over quantity for those exact reasons. And just access to park space in general, like I showed you on the slides. I mean, that does have major impacts for health. So absolutely.
Great, thank you so much. Are there any other questions before we conclude this session? Great questions, everyone. Other questions, other thoughts to share?
I do see that fentanyl test strips are still illegal.
Yes.
Did not know that, so thank you. I'm still going to keep it in my background, so you're all good.
Great.
We're reaching out to the local law schools for help.
Any other questions?
Hi, I have a question. As a patient, is there a way for me to see that I may not getting the best advice from my healthcare professional? Is there a way to check that, or how do I know for sure that, yeah, so it's kind of like, how do you know? And truth be told, sometimes you won't be able to tell.
Right. Yeah, I think there are a couple strategies that folks will use, and maybe there are some other experts on the call. But I do think one of the things that can be really helpful, if possible, is bringing someone with you to your appointments.
Okay.
And it's the same case if folks are in the hospital, your relatives or someone is in the hospital, just making sure that someone's with them as much as you can, because that does make a difference, and that does help give that kind of bird's eye view of like, is something off here, or but it's really tricky. And I know many healthcare professionals are really sensitive about it too. Like, we hate being recorded. We hate, people Googling things, God forbid that, they came out with knowledge and power. So it's a really tricky space, and definitely want to acknowledge how hard that is. And if others have ideas, can throw it in the chat or speak up.
Thank you.
Thank you, Ashley. Well, we want to thank everyone for being present today on behalf of Dean Gerson and the School of Medicine, the Office of Diversity, Equity, Inclusive Excellence, and all of our diversity leaders in the School of Medicine. We just want to thank you all for being present and your contribution to this work, right? And if you have any thoughts and ideas, please reach out to this office. David, how can folk reach you or learn more about opportunities to collaborate with your office?
Yeah, folks can reach out to me directly, dmargolius@clevelandohio.gov. I'm on Twitter as well, as long as that still exists. That's about it as far as social media goes.
Well, thank you so much. Well, Dr. Margolius, thank you so much on behalf of the School of Medicine. We really appreciate your insight, wisdom, and expertise. Congratulations on your new role. It's so good to see you. And
thank you, Tina. Thank you.
You are welcome. And I look forward to continuing our work together.
Great. Well, thanks all for joining, and thanks all for the great comments. I'm just sort of scanning through them now. I really appreciate you all and appreciate the work that you're doing. Thanks so much.
Bye-bye, everyone.
I can't sign off yet. I got to keep reading the,
Yeah, we covered all the questions.
Great.
Yep.
Got some direct messages too. Those are harder to respond to, from
Oh,
folks.
did you? Okay, let me stop the recording.
All right. Well, thanks so much, Tina. Thanks, Philip. See you later. Oh, yeah. Yes, Hattie. Yes. You have a question?
Oh, yes. I didn't have time to say this earlier, but I'm currently a first-year undergrad at Case Western right now, and I was wondering if there was any way an undergrad like me could research health inequity. Like equity research, it has a lot of overlap with sociology and the more macro aspects of it, but I'm a psychology major, at least I'm planning to be a psychology major, and I was wondering if you knew of any places where I could study health inequity at a more micro level. That's something else I've been getting involved in was refugee advocacy, in which like individual stories, needs, and experiences are emphasized. And I was wondering if you knew of any place where I could do research as an undergrad in that environment.
Yeah, thank you for asking. So you're in the right place. There's a ton of work being done to study health disparities right at Case. So I think as a first step, I would probably, do you have an advisor yet?
Well, I'm a declared neuroscience major right now, but I was going to switch that to psychology pretty soon. But my
Nice.
advisor for neuroscience right now is Dr. Barbara Coomerly. And I was also thinking of emailing the Clinical and Translational Science Collaborative, since
You
I
got
heard
it.
that they do a
Yeah.
lot of health inequity research.
You got it. Yeah, I would do all that and more.
Yes.
Okay.
And I have someone you can connect with in the clinical translation department. I can ensure, can you email me at tar5@case.edu?
All right, I'll see you later. Thanks, Tina. Thanks again.
You are
right, all
welcome.
right.
Outstanding job. We appreciate you.
Thank you. Appreciate
Okay,
you.
we'll talk
Bye.
soon. Okay,
Bye.
bye.
Okay, thank you, Dr. Margolius.
Thank you. Great job. Thank you, everyone. Bye-bye.